Chapter 21, Depression and Other Mood Disorders. In page 240, it's talking about the continuum of emotional responses, where the maladaptive responses is like depression and mania, and in the adaptive responses is the emotional responsiveness. Most people will fall in the middle, right? And it goes into in continuum, sometimes going towards the right side or going towards the other side. Theories related to emotions and their disorders, we have the biological evidence that believe that psychological problems are caused by or mood disorder are caused by those neurotransmitters and hormones that are involved with the regulation of the mood. Like the monoamines are longer acting neurotransmitters that modify the sensitivity of the neurons. The pituitary gland controls the hormones by balancing the thyroid and the adrenal hormones. This theory believes that depression is related to physical illness. There's some also other theories that talk about the emotions and their disorders. Psychoanalytic talks about those mood disorders, and they see it as anger is turned inward. Behaviorists also view depression as a group of learned responses. There's also like social theories that consider depression as the result of problem with social interactions, and a holistic viewpoint as is usually used by healthcare providers. Well, holistic viewpoint is taking care of the patient or looking at a person in a holistic view, like the whole person, not just focusing on one disorder or the disorder and disease of the patient. Emotions throughout the life cycle. So in childhood, there will be like incidents of depression. This is not common, but is increasing, right? Depressed children have a distinctive way of thinking, and there's what we call situational depression, which is when there's a depressive response that in children that is tied into a specific event or situation. Depression in adolescence is usually related to four factors. It's either self-esteem, low self-esteem, loneliness, family strengths, and the parenting communications. So the depression in adolescent can be um, prevented if they're actually good with these four factors, right? For example, what if the teen has a good or a high self-esteem, right? And is not having any loneliness. The strength of the family is actually strong. And then the parent and teen communication actually is a therapeutic relationship. So the depression in adolescents can be prevented, right? But usually it's related to these four factors. Also, control issues. During adolescence, there's a control issue problem. It's developing. They want to be in charge, right? They think that they know everything, that the adults, and then the adults know nothing. Another contributing factor is the hormonal change, right? Hormonal changes during puberty that can also affect the emotions in adolescence. Emotions in adult is dictated by the societal norm. A society expects the adults to practice emotional control, right? You don't, or the society actually is not going to expect to see an adult actually throwing a tantrum in a store, right? If they cannot buy something, not like, in children. So there's like a a norm that the society is expecting from adults when they're actually having that. emotional control. Adults must cope with a wide range of situations, events, developmental tasks, and responsibilities, as well as emotional reaction. And public stigma follows individuals with mood disorders. For example, patient that has a diagnosis of bipolar, right? There's going to be like a stigma, or even schizophrenia. There will be a public stigma that follows the mood disorders. Emotions in older adulthood, depression is very common in older adults and but can be treated. So as the clinicians or the caregivers is taking care of the patient, how do we detect the depression in older adults? Well, the most important thing, and I have been saying it, is active listening, right? We gotta make sure we know how to actually listen to our patient. Active listening. Also, gentle questioning, right? You want them to, when they tell you something, you want them to actually elaborate. What do they mean by that? Alert assessment. So you're listening, you're doing gentle questioning, and then now you gotta make sure that you're also being alert when you're doing those assessments. Um, because early intervention is very, very important when we're taking care of those depression um, in older adulthood. Mood disorder. So you have mania and you have the depression, right? Mania is when the emotions are elated, expansive, grandiose thoughts of and actions. Patient might be irritable and accompanied by loss of identity and increased activity. Um, and then depression is feelings of sadness and disappointment and despair. So these two right here is your bipolar disorder, right? One pole is the mania or the manic episode where the patient has those grandiose thoughts and actions. And then the next and the other pole is the depression when there's a feeling of sadness and disappointment and despair. Mood disorders. Depression can occur in several levels. It could be mild, moderate, and major. Okay, mild depression is short-lived and is usually triggered by life events. So there's like something significant that actually happened and caused the depression. It's mild depression. It becomes moderate depression when it persists over time, and we call it dysthymia. And then major depressive episode is when the depression is severe and lasts longer than 2 weeks. Okay. Symptoms range from paralysis to agitation, and suicidal thoughts actually may be present, right? Bipolar 1 and 2, let's compare them. Bipolar 1 is episodes of depression alternate with episodes of mania. Bipolar 2 is when there's major episodes of depression alternate with periods of hypomania. However, between the two, bipolar 1 is more severe and the incapacitating form of bipolar illness because there's like higher highs and lower lows. That is how bipolar 1 is. Okay, delusions are more common during the periods of mania, and hallucinations are not common but may be present. For the bipolar 2, um, often marked by 1 to 2 weeks of severe lethargy, withdrawal, and melancholy, followed by several days of mania. And for bipolar 2, the mood swings are less drastic. That's why the bipolar 1 is the more severe than this one. And then we have cyclothymic disorder, which is a behavior of repeated mood swings alternating between hypomania and the depressive symptoms. Seasonal affective disorder, from the word itself, is seasonal. This occurs in many people from October to April. And then we have postpartum depression that occurs after childbirth. Symptoms include tearfulness, irritability, hypochondria, where they think something is wrong, even if they get checked and nothing is wrong, sleeplessness, impaired concentration, and headache. And these symptoms are severe, okay, to the point where it's affecting the activity of daily living of the person that just had a childbirth, okay? Okay, therapeutic plan for mood disorders. We have acute treatment phase, continuation phase, and the maintenance treatment phase. This phases is in page 246, table 21.2, phases of treatment for depression. Acute treatment is 6 to 12 weeks time period. The goal is to reduce the symptoms of inappropriate behavior. For the continuation phase, this is 4 to 9 months, and the goal is to prevent relapses into distressing emotional state. And maintenance is indefinite, and this one is to prevent the recurrence of the depression. In addition to that, table 21.1 in page 244 is levels of manic episode or manic behavior, sorry. We need to know this, so please highlight them: hypomania, mania, and the delirium. And hold on. Also, box 21.2 is in page 241. We need to remember those adults that are at risk for depression. They are women, people between the age of 35 and 44, white and Hispanics, individuals with fewer than 12 years of school, people who live in major urban areas, people with physical illnesses, recently widowed older adults, and people who live in the Western United States. What are current standard treatments for mood disorder? Either psychotherapy, right, individual or group, pharmacologic therapy, which is the medications that we give to the patient, and then electroconvulsive therapy also can help, which is like those shock that we did talk about. It's kind of like resetting the chemicals or the um, electrical signal in the brain. Drug therapies. So antidepressants, you have the tricyclics, non-tricyclics, monoamine oxidase inhibitors, and selective serotonin reuptake inhibitors, SSRIs, and atypical antidepressant. These medications are listed in box 21.4 in page 247. Please read and remember them. Your TCAs, monoamine inhibitors, SSRIs, SSNRIs, serotonin modulators and stimulators, serotonin antagonists and reuptake inhibitors, norepinephrine reuptake inhibitors, and tetracyclic antidepressants and other depressants, and mood stabilizing drugs. So very important to remember and read this box 21.4 in page 247. Okay, with many antidepressants, 2 to 4 weeks is required before their effects are noted and the client's well-being improves. Okay, it doesn't take effect right away, so we have to educate the patient and monitor the patient, because this antidepressant actually takes 2 to 4 weeks before they take their effects. In addition to that, we want to monitor our patient with the side effects of antidepressant, which is in page 248. We have to know this. Sorry, 200. Yes, 248 in table 21.3. These are the side effects of antidepressants. We have to know them, please. One thing that I would like to point out is that when we start patients on antidepressant, we now need to monitor the patient for increased suicidal ideations or suicidal gestures, the increased risk for suicide. The reason being is that you're giving them medication that is actually making them more active and making them more um, energetic. So there's more energy. So now the risk for suicide increases. Okay. So when we give antidepressant, we now have to monitor the patient for suicide, at risk for suicide. Okay, lithium is an anti-manic medication, and we use this for bipolar disorder. In page 249, we have to know the side effects of the lithium. And lithium is a naturally occurring salt that helps to control the exaggerated thoughts and behaviors that is associated with mania. Okay. However, another thing that we need to remember for lithium is that the therapeutic blood level is zero point 0.6 to 1.2. Then the toxic level is actually from 1.5. You see how the difference is only zero point 0.3, right? The therapeutic blood level is zero point 0.6 to 1.2. The blood level of toxicity is actually starting from mild toxicity, which is 1.5, and the moderate toxicity is 1.5 to 2.5. Severe is above 2.5. And we need to know the signs and symptoms of lithium toxicity, by the way. It's in page 250. Please know them. Like I said, there's mild, moderate, and severe toxicity, and the signs and symptoms that we actually have to look out for. Side effects and signs and symptoms of lithium toxicity is the same. That's why it's a little challenging. It's challenging when we're giving the lithium, because we need to like distinguish, is this still a side effect or is this the toxicity of lithium, because they have the same manifestations, the side effects and signs and symptoms of toxicity. So what we're gonna do is we're gonna watch if the signs and symptom will disappear in 6 weeks, right? In 6 weeks. And if it does not disappear in 6 weeks or within 6 weeks, you have to be alert for the possibility of early lithium toxicity. In addition to that, because lithium is a naturally occurring salt, we also have to make sure that we're taking in consideration the salt or the level of consume, or the level of the salt that the patient is actually consuming. And why is that? Well, in page 249, let's look at that. It says lithium is a naturally occurring salt that helps to control the exaggerated thoughts and behaviors associated with mania. Because lithium does not bind to body proteins as do many other drugs, it does not need to be metabolized by the liver. Lithium is distributed throughout the body fluids where it competes with sodium. It is excreted by the kidneys more rapidly than sodium. Therefore, an important interaction exists between the level of lithium in the blood and the amount of common table consumed. When patients who are taking lithium ingest large amount of salt, the lithium levels usually drop because of rapid kidney excretion of lithium. But the opposite is also true. When clients decrease their salt intake or lose salt through sweating, diarrhea, or altered kidney function, lithium levels in the blood are likely to increase. Because the range between therapeutic response and toxic effects is very narrow, clients must be instructed to avoid changing their diet or activity habits abruptly. Nursing care for patient with depression or mania, we have to assess, right? Assess for level of depression or mania. We did talk about those mild, moderate, and severe, and then the panic. We need to know them, and we need to know the nursing diagnosis. Nursing interventions. Once you diagnose a patient, then you would know the therapeutic intervention that we can do for the patient. Um, and again, when we take care of this patient, we gotta make sure that we're doing it in a holistic approach, right? Holistic interventions. We should look at their physical, their emotional, their social, intellectual, and spiritual care of the patient.